Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran. And once again, I'm so happy to have the chance to be with you all from this educational platform with great lecturers from around the globe that share their time, the valuable time and knowledge with us, and all the dentists and practitioners for helping us improving the knowledge of implantology, periodontology, and all the related fields and aspect of it. Today, I'm very happy to have a very dear friend from Spain, Juan Lara Chao, is here with me. Hello, Juan, and welcome to Hot Seat, my friend.
Hello, how are you doing?
Thank
Thank
you.
you, Omid. Glad to be here with you.
Thank you so much, my friend. The pleasure is mine. And for all the audience joining us today, we have a great topic again. The reason that I'm saying it great because over the past sessions, we decided to talk a little bit on advanced cases and different techniques and approaches in bone augmentation procedures, in soft tissue augmentation procedures. And today is one of those related sessions in the advanced procedure because Juan going to talk about severe bone defects in oral implantology, how to manage them, how we should proceed in the procedures, and what are the options and criteria that we need to take into consideration. So Juan, before we start the presentation, I would like to have your CV for all of our audience, and then we will go to the presentation, and at the end, for sure, as our routine, we're going to have a great discussion on the topic. Dr. Juan is a clinical professor in oral surgery and implantology at URJC Master, clinical professor in periodontics, implantology, and prosthodontics at Alfonso X University Master, clinical professor in oral surgery and implantology at Alcala University Master, and master's degree in oral implantology from Alcala University. He has lots of national and international lectures, specifically in the field of oral implantology and bone grafting, and his practice is exclusively dedicated to implantology and bone reconstructions. With that said, my dear friend Juan, we are ready for your beautiful presentation, and you can share your screen, my friend.
Let's go for it. Okay. Let me see. Can you see now my screen?
Yeah, perfect.
Okay. Well, first of all, thank you, Omid, for this. It's a pleasure for me, and it was for Jose that was also here. And thank you so much. It's very kind of yours. We are going to talk today. I say we because we are doing always these lectures, me and Jose together. So this lecture of today is going to be severe bone defects in oral implantology, which is, as Omid said, is a field that we really like it. So let's go for it. First thing is to know a little bit of bone graft biology. Why? Because we need to understand why we are having not very success sometimes in these augmentations. Usually for vertical augmentations, we use autogenous bone. Why? Because biomaterials in vertical augmentations, sometimes they are difficult to obtain good results. But also with autogenous bone, we are having some problems. Let's see what are the biggest problems we have with this kind of reconstruction. One of the mains are bone resorption, as you already know. Usually when we talk about autogenous, the second part of the sentence is yes, but autogenous get resorbed. Correct, correct. If we go to the scientific literature, we can see that there are many articles talking about bone resorption. We would like to point after a 6 years follow-up in iliac crest grafting, she showed us in this honest paper an 87% of resorption, which is a lot. Okay, but we could say, okay, we knew already that iliac crest get a huge resorption. Why don't we go to another part of the human body to compare. Okay, in this other article, which compares iliac crest with calvarian bone from Carinci, he compares the resorption rates in both with both kind of autogenous grafts. And if you take a look to this graphic, we can see the line here. I don't know if you can see the mouse. This line. Uh, First thing is this is the iliac crest resorption, which at the very first measure we already lost 10, 20, 35% already. So the moment we place it in surgery, we have 100%, and the first time they get the first measure already lost 35%. But this is the important fact is that once it gets resolved, it is stable. Okay, on the other hand, if we go to calvarian grafts, we can see at the first time it is stable, even in the first measures, we have 100%, but little by little, it got resolved, and it tend to get to the same point to the iliac crest. We have almost the same resorption within 4 months after the bone graft. Why is that? Okay, these autogenous bones resorbs, but they resorb in a really, really different way. Iliac crest resorb really fast at the beginning, but once it gets vascularized, it's going to be stable. And the calvarian is the opposite. It's really stable, but then it goes the resorption, and they come to the same way. Why is that? Iliac crest is really spongious. I don't know if you have the chance to touch iliac crest. Is really spongious bone, is really fragile, and it doesn't get well with traumatisms. So at the beginning, with all the traumatisms of the mouth, the muscles, the foot, etc., it gets a huge resorption of impacts, but once it gets vascularized, it's stable. On the other hand, a calvarian bone is the opposite. It is really hard. You cannot squeeze it with your hands like the iliac crest, and even if you hit it with a hammer, you're not going to break it. The problem is that it's really thick and it's really dense, so it has no chance to get revascularized. So at the beginning, it has no resorption because it handles really well the impacts, but little by little, because it's not revascularized, it's going to get resorption. Okay, if we continue in our way of looking to the scientific literature, you can see two papers we already talked about. In 2013, Stavola published a technique that was unpublished in the scientific literature yet, because Pat Curie had his book in 2013, but he didn't publish yet. And he showed us 8.4% of resorption in posterior mandible, which a 3D tunnel technique, which he called, it didn't have a name yet. And in 2015, Restoy, which is our team for the hospital, we published 50 cases, all of them in posterior mandible, with a resorption of 0.9 millimeter after a year of loading, with a 5 years follow-up. Okay, let's see, or let's understand how Curie managed to build this kind of graft. First thing is, let's mix both grafts. Calvarian is really hard, but it's really dense. It's going to get resorption because it cannot get revascularized easily. And iliac crest is very spongious, but it gets vascularized really fast. Okay, what Curie says, he's going to mix both techniques, and he's going to harvest a bone block from the mandible. And when we have the bone block, we're going to split it in two thin bone blades. Why? Because we are going to get the calvarian bone like the calvarian bone. The mandibular bone is like the calvarian bone, which is really hard, but we're going to make it thin, really thin. Why? Because the thinner it is, the more chances it's going to have to revascularize. So look at this thing, is like 0.8 millimeters, 1 millimeter, maybe 1.2 millimeter, no more. It's very thin. And now that we have this thin bone blade, we are going to reconstruct all the box shape of the graft, leaving a gap inside. Why are we going to do this? Because we know that calvarian or mandible bone graft is hard, is really well to handle traumatism. So we are going to put it on the outside to act like a shield, a bone shield, to protect our bone graft. And we are going to fill that gap we have inside with an spongious bone, which is like iliac crest bone, that is going to get easily vascularized and is going to be protected from the traumatism with the mandible thin bone blades. So this is the structure Curry designed and called split bone block technique. Okay. After 4 months only, we are re-enter the implants, and in the same site we are drilling to place the implant. We are harvesting a bone core that we are going to analyze in the histology lab, and they're going to tell us which kind of bone do we have inside. We want to know how is that bone? Is it vital? Is it vital? How it is after 4 months. So this is the histopathology, the pictures. And if you take a look to the picture, you can see these little structures which are violet with a nucleate pigmented inside, which means that this osteocyte is vital. Every time we have this structure with a nucleate inside, we can know it's a vital osteocyte. And we are also looking for this chain here in the sides of the bone part, which is the osteoblast, that its presence means that we have an unmatured bone. It's a young bone. So seeing this picture, we know already that after 4 months, we are having a vital and a young bone. It's growing bone because it's really soon, only after 4 months. We are not waiting 8 or 10 or 9 months for placing the implants. Okay, this is all the theoretical part we're going to see, and let's go for clinical cases. In this case, you can see the upper left first molar. We have a big periodontal defect. Of course, this molar is moving. It has a lot of mobility, and I think we all agree we have extracted. But if I ask you if we have to extract also the second molar, we don't have to extract the second molar because it's not moving, but if we want to reconstruct from bone peak to bone peak, we need to remove it. Why? Because bone reconstructions on Spose's root are not predictable. So to remove this tooth, and we are going to find one beautiful bone peak here, and we are going to reconstruct to this other bone peak in here. Okay, first thing, we remove the tooth and we wait some months. Why some months? We not only need a soft tissue closure, what we need is a soft tissue closure at enough thickness in order to close our flap when we, in the future, we will be doing this bone graft augmentation. Look here, this is the defect here. Could maybe perform a sinus lift? Yes, we could perform a sinus lift and place the implants up here, and we will have a crown the same length of the premolar with the root and everything. So also we have the sinus lift, as you can see here is not a clean sinus, it's dirty, and we prefer reconstruct all the bone that the patient has lost and place the implant here where it's supposed to be the teeth. So this is the CBCT cuts, and as you can see, the palatal bone is even in a lower position than the bone. We don't have bone at all. We don't have any bone. The alveolar process should be in here, but we don't have at all. We have a completely lack of alveolar process. So this is the picture right before the surgery, and one main point in this kind of big reconstructions is before opening, thinking how we are going to do the closure. And in these cases, one of the main problems is the essence and the exposure of the graft. We know that if we have an exposure of the graft, we will probably lose every single part of the graft. We have an exposure, probably we're lost. So we are not doing an open approach, a crystal incision to raise a flap because well, there are many wound diseases. We have in the literature, we have a report between 30 and 40%. And also there is not even one paper that compares the wound adhesions with the amount of vertical millimeters we are gaining. So I'm sure that if we all do 1-2 millimeters verticals, we are going to be quite successful with our grafts. But if we go for a 9, 10, 12 millimeter bone graft vertical, we're going to have a lot of exposure. So to avoid these exposures, what we are doing is just one single incision and working through a tunnel in order to reconstruct this defect. So as you can see here, this is the only incision, is only one. We didn't to do the second incision when we go to the mandible is only to harvest the bone block. So with this incision is more than enough. And look at here is 3, 6, 9 in this point, which is the worst, but 9, more or less 9, 10 millimeters. We're trying to reconstruct here. We already placed the crystal thin bone blade, harvest a bone block, we split it into thin bone blades, and one of them we place it here crystally, and we fill the gap with autogenous particulated bone, and after that we are going to place the other thin bone blade backly. In the palatal, we are not placing any bone blade. We are just placing particulated bone, that's all. So this is the reconstruction once it's finished. You can see we tried to place the screws in other holes, but we couldn't because it was such a big defect that with these 12 length millimeter screws couldn't get to achieve stability. So we have to try several times until we get the stability we were looking for. Now this surgery has one benefit, which is really easy to suture. Just 1, 2, 3, 4 stitches, that's all. And we do not need to cut the periosteum in order to have more soft tissue, because when working through a tunnel, it's not neither that. We have more than enough. Look, this is the closure. There is no tension at all. It's a free closure tension. And you will be asking, okay, how can it be possible if I do an open approach and I don't have enough soft tissue to close the wound, and working with a tunnel there is more than enough. You said I am saying soft tissue to close. How is that possible? Because the tissue is the same, more tissue. The trick here is that the fundal vestibule becomes flat. So our patients after this surgery, they usually tell us, everything is very good, doctor, thank you, but when you did the surgery, I don't have the fundal vestibule, I don't have that a little pocket there. That is true. That is the cost of the tunnel. But in the future, we will show you how to fix this situation. So we are waiting 4 months only, and 4 months later, we are placing the implants. Let's see an X-ray. This is the situation 1 month after the bone graft. As you can see, looks quite good. We place 6 screws, 3 from the crystal and 3 from the buccal bone blade, and we fill the gap really well. We don't want any empty space, because empty spaces they're only going to get filled with soft tissue, so we avoid to have empty spaces. And now look, we could place here one implant without going into the sinus at all. This is the situation 4 months later. And here where you can see the screws up to the head inserted in the bone. But here we have a little bit of resorption. Why is that? Well, in fact, I wouldn't call this resorption. I would call it remodelation. Why? Because we overgraft a little bit because the maxilla is round. Here is round, but we place a straight thin bone blade. So everything that gets out of the frame is gonna get remodeled to the frame, to the maxilla. We do not overcorrect. We always just graft in between bone peaks, and we know that everything that goes out of the frame is gonna get remodeled. So this is the bone graft, and look at this beautiful picture where we can see the crystal thin bone blade, the buccal thin bone blade, and also some of the particular bone here in this triangle. Okay, the bone looks quite good. We have tiny vessels that made us think that this bone is vital, but we are gonna take, like always, a biopsy. Here it is. We take our biopsy and we send it to the lab always, so we can know which kind of bone we have there. Okay, just place the implants. In this case, we place two implants because in the posterior side, we try not to place only one implant for a first molar. The forces, as you know, they are really high. So if we don't have first and second molar, we place two implants for a second molar. If we don't have one bicuspid and two molars, we place two implants in the second bicuspid and in the second molar. And if we miss the two bicuspids and the two molars, we place one implant in the first bicuspid and one implant in the first molar. So, and we always tell the to do in order to the forces to be handled by two implants. So this is the situation 3 months after we place our implants. Look at the beautiful bone we still have in here. We don't have any resorption. It's like we just place the implants now. And look at this incision we are making here in the palatal, because we want to move all this keratinized tissue to the buccal in order to have keratinized tissue also in the buccal, not only in the palatal. It's very important to manage really well soft tissue in order to have keratinized tissue all around our implants. Okay, this is the two implants in place. We're gonna place the healing abutments here, and let's go for X-ray to see what happened inside. This is right before doing the second stage surgery. We still can see a part of the thin bone blade here and here. Take a look. I mean, all this part in between the two implants, all this bone, it looks like a regular bone. I mean, there's no difference in between this part and this bone that the patient used to have here. We can see a little bit of a scar bone here where the bone defect was, but this doesn't look like strange at all. It's like a regular bone. If we compare how we were in 2016 with this big defect and how we are now, well, it was in 2019. You can see the two implants are in place. 3 years later, nothing happened. We have bone, and the patient is eating with any problem unhappily. Let's go for another side of the mouth. This case, a really interesting case for me. I really like this case because it was a young lady. She has some teeth missing since she was born, and she was some years ago, 6 years ago. And look at this picture, as you can see here in the anterior mandible, the soft tissue doesn't look really good. And if we remove that prosthesis, we can see this situation. She had placed two implants, bone loss happened, soft tissue is really bad. We don't have keratinized tissue at all. We have many muscle insertions here, and the implants are really full of dirtiness. So for the patient is painful, soft tissue gets swelling. And if we take a look occlusally, we can see the Wharton conduits in here. I don't know if you can see well. One Wharton conduit is here, the other one is right there. And we are having a reto infection because of the dirtiness, and it's a little bit inflamed, a little bit swelling here, both of them, because these Wharton conducts, they are too crystally. They should be way more lingual, and they are too crystally. Okay, I think we agree we should remove these implants. And how are removing implants nowadays? With a kit, no? We have these removal kit instruments that they go with 200 newtons force, trying to unscrew the implant. But remember, anterior mandible, really dense bone, really long implants. These implants were 16 millimeter. What is going to happen? Probably it's going to break. The forces of torsion, they are so huge that both implants broke when we were trying to remove them. We're trying to unscrew them. What option do we have now? We have the option of a treffing burr. So we don't have many more options. So we have to remove both implants with the treffing burr, and we also remove the two tooth we have in the sides. Why we do remove this tooth? Because you can see here we didn't have bone. We didn't have bone. We have bone loss also, and as we said before, we cannot reconstruct. It's not predictable to reconstruct on roots exposed, on exposed root. So this is the defect. More or less it's going to be 14 millimeters, maybe this is 12. Yes, more or less 14 millimeters defect. And well, first thing we're going to do is we're going to wait. We need these tissues to heal, to get thicker, and we are going to wait. In fact, one little trick, we like to tell the tricks because we think it's the most important part, because we all know can learn the techniques from a book or from a teacher, but the tricks are the one that gives you the handy part. We are not closing first approach because two reasons. If we close this perfectly well, primary intention closure, we are going to have first thing, we're going to have the Wharton conduits crystally again. And if we leave it a little bit open, in between keratinous tissue and keratinous tissue, grow more tissue. So with leaving like this, we are going to get more chances to get a little bit of keratinized tissue. So we are waiting 3-4 months, soft tissue to heal, and look at the implants we just removed. This is what is 1 millimeter more here, 10, 11, 12, and one more 13, plus the part that broke at the beginning, which was like 3 millimeters more, so it was like 16, 17 millimeters length. And this is the situation 4 months later. As you can see, even outside, even without the opening a flap, we already have a pretty big defect. This is a 30-year-old woman, and she wants her smile back. I mean, he wants her tissues, her bone, her everything, her teeth back. So we measure our defect is 6-7 millimeters. No, sorry, it's 3-6 more than, it's like 9 millimeters, and we are not counting inside the inside defect, which is probably even more. So at this point, we were thinking, which approach are we going to use? If we go for an open approach, crustal incision, it's good, it's okay, but again, we are going to move the Wharton conduits on the top of the crustal, and we are trying to move them back lingually. And with this soft tissue, which is really bad, we're going to probably need, we're going to probably have some trouble closing, and it's risky for us. It was risky. Another option, it was a vertical tunnel like we did in the previous case, but in the mandible, because it's almost round, it's going to be really difficult to reconstruct all that through a vertical tunnel. So we went for an horizontal tunnel, and we did an incision in the funnel vestibule, like a Kashanjian approach, like a Kashanjian vestibuloplasty of Kashanjian. But instead of leaving only the mucosa flap, we are going to leave a thickness flap. We want a thicker flap. Sorry, we need thickness in order to protect our bone graft. We do not want a really thin layer protecting our graft. We need a thicker one. So we just went forward. We took the mucosa and part of the muscle, and we open from the fundal vestibule. We harvest a bone block, divide it, split into thin bone blades, and reconstruct one thin bone blade. We place it crystally, fill the gap as much as we could with particulated bone. You go, look at the thickness of the flap. And now we do not have a thin bone blade round, so we needed to place two thin bone blades, one in each side, closing the box-shaped graft in order to finish this reconstruction. Okay, now with this thickness, we can do internal sutures all here to here, and we can closure this perfectly well. Another trick is that we didn't close mucosa with mucosa, I usually do. We close mucosa, and this is the mucosa, to the muscle. So this is the one mucosa, and this is the mucosa. We didn't suture this part with the other part. We closure this part to the muscle. So we move a little bit all the tissue lingually, again, for the Wharton conduits, and also we are protecting and we are not having such big tension in our flap. Okay, 10 days later, this is the situation. It heals quite well. We can see some stitches. These are the stitch here. And well, it looks pretty good. I mean, the patient had, of course, swelling. She didn't have pain because harvesting a bone block is like removing a wisdom teeth. If you good medication, patient gets swelling, but it's not painful. And this is the situation 3 months and a half later. Look at that. We have restored the volume, but we need more things there. We need soft tissue, and we need, of course, we need implants. So at this moment, we are going to open in a crystal approach. We're going to remove the osteosynthesis screws, and look at this. We have a remodelation of the thin bone blade. It used to be rectangular, but now, because of the forces of the tongue and the traumatism of the tongue, it remodeled because we were out of frame. So it's going to remodel to the frame again. So we have this round part, but look at this. I mean, this thin bone blade get remodeled and is one piece with the mandible of the patient in here, and the aspect is really good with the little vessels and veins and blood. So this patient has a 5 teeth lack. She had 5 teeth. So we came to an agreement with the prosthodontic to place 3 implants. All of them were narrow diameter. They were 3.4 millimeters diameter. Okay, so we always submerge our implants following Linkevicius studies, and we are going to wait. We are going to wait 3 months more in order for the osteointegration to happen. Now, 3 months later, what we have to do is we have to check how is our soft tissue. Soft tissue here is not very good. We have muscle insertions. Keratinous tissue is almost not present, a little bit here, nothing in here. So we need also keratinous tissue, and another thing is that we check our Wharton conduits, and they are already in place. As you can see there, they are lingually. So we are very happy about that. And the gold standard to obtain keratinous tissue nowadays is the fringillobacter graft. We love this This technique is really predictable. We are just doing a free gingival graft approach. As you know, in mucogingival junction, we make an incision, we leave a periosteum bed, and we place our free gingival graft on it. Okay, 1 month later, we are going to recheck the patient to see how she's doing. And this is the situation. Now we have keratinized tissue. Yes, here we have keratinized tissue that we can divide in two parts because we are looking for having keratinized tissue in the buccal and also in the lingual, not only in the buccal. We need keratinized tissue all around the implants, and we are going to perform the second stage surgery. Okay, now we have tissue, we have bone, and we have our implants. But let's check how is the soft tissue thickness. As you know, again, in Kivicius articles, we need at least 3 millimeters. This is not 3, this is 2. So we will need to do something here. But take a look at this picture. As you can see in this implant on our left, there is a little bit of bone that has grown over the implant. In the center is full with bone on the top of it, and also in our right is play covered. What does that mean? That means that that bone is vital. I mean, if it wasn't vital, it wouldn't have grown over our implants. So with vital bone, of course, we also took a biopsy as we always do. And now we're going to take advantage situation to get a thickness, a thicker soft tissue. How are we going to do that? We're going to harvest a bone, a connective tissue graft, a connective tissue graft with one incision technique. We are going to leave the epithelium, and also we are going to leave the periosteum. So the post-op of the patient is going to be much better than when we remove the periosteum or when we remove the epithelium. The post-op of the patient is painful. So we just remove the connective tissue, leaving those two layers, one on each side. Okay, this is our connective tissue graft. And because we want to have 360 degrees soft tissue all around our implants, we are going to perforate this graft, and we are going to put through it our gingival abutments. We are going to make sure that the gingival abutments get fixed well with an X-ray into the implant, and this is how it looks like before surgery. And you see here our connective tissue graft all around this implant, the one on our left. The central implant is the same, is full all around with connective tissue graft, and also here that was the gingival abutment we saw in the last picture is full with surrounded with keratinase, with connective tissue graft. Now we're going to do the closure that way, and we are going just to wait 6 weeks to heal. 6 weeks later, this is the situation. Look, now we can see we have a beautiful soft tissue. We have thickness. Even one of the implants got submerged because of the soft tissue grew over. So we have a lot of soft tissue, and the two other implants are here. Okay, remember how we have this patient before reconstructing? Look at the defect. We didn't have bone, we didn't have implants, nor keratinized tissue, and nor thick tissue, and how it is now right before we send the patient to the prosthodontist to do that prosto work. Unfortunately, we don't have the pictures of the prosto yet because we have to tell them and email them to send this, which is difficult. And let's move to another case. This case is really interesting also for us because this wife's patient emailed us some years ago, and she told us the following story. She told us that her husband has a traumatism. He lost the four incisors, and he had a GBR done. After the GBR, they got an exposure and they lost everything, waited some months, and another colleague did two bone blocks, and both of them got exposed also. That is bad luck, but this is quite big. So this is the picture the patient sent us of the second exposure, because he already knew that something was happening, and he took a picture himself to the second exposure our colleagues had. Okay, so he come to us, and this is the picture of the mouth of the patient, where we have a bone loss, of course, and we also have the soft tissue attached almost to the palatal. I mean, there is no funus vestibule at all. The funus vestibule is absolutely flat, and the insertions come all the way to the palatal. Okay, first thing, we always try to think if we could replace in the easiest way possible. So this is how it was, and we were trying to imagine what if we could place a short implant. If we place a short implant, we will have a crown the size of the premolar with the entire root, all of it, and it would be a 7 mm implant with a 25 mm crown. Okay, but as we know, when we place zygomatic implants in the zygomatic bone, we know that only 8 mm go into the zygomatic bone, and the 4 cm of the rest of the implant and the prosthesis stays almost in the air. Yes, that is correct, but how is the zygomatic bone? Is it hard or is it spongious? It is really, really hard. I mean, the zygomatic bone is almost all cortical. It's a really dense and really hard bone. How is the maxilla? Is it really hard? Is it very cortical in the mandible, or is it really spongious? Correct. It is very spongious. And even more, this patient didn't have the best quality bone in here after a traumatism and two exposures. So we weren't confident that these short implants, in this case, were going to last many years. The patient is only 40 years old, so we needed something more, for us, more predictable. So which technique are we going to use? We were quite comfortable with Curie technique. In fact, we published this article of three-dimensional big severe defect in the maxilla, and we were having good results using these techniques. So we choose to do it with spring bone block technique, and the problem was, okay, look at the soft tissues. I mean, the mucogival is here in the palatal, right there. We didn't have funus vestibule at all, and the soft tissue were really bad. So should we repeat the same approach again? I mean, if two colleagues had already exposure doing that approach, we would probably have another exposure if we would have done an open approach, a crestal incision. So we just thought we should change this approach in order to have different results. We were quite confident in working through a tool. This is one of the articles we had about tunnel reconstructions, 50 cases up to 5 years, but all of them were in the posterior mandible. We were quite confident doing this tunnel approach, but in the posterior mandible can be easier because it's straight, it's not curved. So the problem is doing this tunnel in a curve, it was more challenging, but have much option because crestal approach for us wasn't an option after two exposures of other colleagues. So we formed two vertical incisions, one in each side, and communicate both incisions with a subperiosteal approach. Once we have that, we went to the mandible, we harvest a bone block, we cut it down to size, always less, at least 1 millimeter to the teeth. We don't want to touch the roots or the teeth with our graft. We always leave some margin there. We are going to place this thin bone blade crystally, right where it is, but inside the tunnel. So we just place it inside, and this is the reconstruction. Let me stop a little bit in this picture, so you can see that this thin bone blade is the crystal one. We fill the gap inside, all of it really well with particulated bone, and this is one of the two buccal thin bone blades. Again, like we saw in the previous case, we placed two thin bone blades buccally and one crystally. Okay, that is really good, but you are probably asking yourself, okay, Juan, this is very good, but what about the root? You told us that you are not going to grab over exposure root, and here I can see a root. You are correct, but this exposure root is buccally, and we are not touching that with any bone graft. We are touching here in the mesial part, that is where the root, the teeth, has bone, okay? So we are not touching here at all. We are only touching where the bone is present. And to prevent having a recession here, because we did an incision over an exposure root, and it's going to be a big traction of the flap because of the big defect, we are going to harvest a connective tissue in every incision, the two of them. We are going to protect these incisions with a connective tissue under the flap. So this is how it looks like after we did the closure. These stitches here in the palatal, they are keeping in place the connective tissue, which is one here and another one here, and these stitches, they're closing our tunnel approach. Okay, this patient, he wasn't from Spain. We are placed in Spain, and he was from Haiti. So it was a big journey from Haiti to Spain. So we have to manage quite well how we were going to do all the appointments. So the patient left Spain and he came back 4 months later. We did the follow-up through a friend dentist, which is there is a local dentist, and he was sending us the picture of the patient. And we took this picture when the patient came back to Spain. And look at this. I mean, in the previous cases, we are doing tuner approach. I told you that the phonous vestibule becomes flat. Okay, but in this case, because we already had it flat, the phonous vestibule became inverse. It was outside because it was so much volume that we didn't have soft tissue, so it was out of where we should be. Look at this. We have a lot of tension in the sides, just only with the retractors and not pulling at all, we already have a lot of tension. So we knew that if we perform now a crestal approach to place the implants, we are going to probably have an exposure, a late exposure, but we are going to have it. So we wanted to avoid exposure, so we modified our protocol, and we are not going to place the implants yet. First thing, we are going to get better soft tissues. How are we going to do that? We are going to graft a gingival. We are going to graft with a gingival graft and move all the phonous vestibule and the mucous joint to the phonous vestibule. So look at this, a really big gingival graft, and keep in mind that this is only crystally. I mean, we are not grafting buccally. Here is only crystally. It was a big patient, and we need a lot of tissue to graft. So, okay, this is some weeks later that the patient stayed in Spain. it heals really nice, and he came back a couple of months later, 2 months later, and this is the situation. Now we have here enough keratinous tissue. We don't have much funobestible, but at least it's not palatal. It's buccal crystal situated in that place. So now we can place our implants. We ask for a CBCT, and this is the previous the CBCT, and this is the after the CBCT, the post CBCT, where we have 14 millimeters to place our implants. If you take a look at the right part of your screen, you can see how this screw is 12. We have a beautiful bone and another 12 screw there. Okay, now we have to place our implants. At this point, we're going to open with a crestal approach, not touching the papilla. And what are we going to do? Are we going to place 4, 3, or 2 implants? We went for 2 implants, and probably you're asking if we place it in the central incisor, in the lateral incisors, or one in the central, one in the lateral. We decided not to place one in the center and one in the, and we decided not to place in the laterals. Why? Because even though, as you know, if we place in the central, we're going to have a cantilever in the laterals are the teeth that has the less forces of all the maxilla. And if we place it in the laterals, those implants are really difficult to place because laterals are really small, and any little margin can make a change of the aesthetic outcomes. And also we would have a cantilever anterior because the bridge would be round, and we will have a cantilever in the centrals that are supporting more force than the laterals. So following Xavi Vela and Xavi Rodriguez, two Spanish dentists that published the outcomes of placing 2 implants for 4 incisor, they came to the agreement that the better aesthetics outcomes is placing the implants in the centrals. So we harvest a bone core always for a biopsy, and as you can see, osteocytes, some osteoblasts, and looks pretty good. Okay, place our implants. We always submerge our implants, and just wait. 3 months later, this is the situation. Now we have a little of keratinized tissue in the crystal. We do not have funobestible, and we have our implants. Okay, what we are going to do now, we are going to take advantage of the situation again, and at the same time we are doing the second stage surgery, we are going to regraft, doing another frigidal graft, but this time is going to be buccal. We want to have keratinized tissue also buccally, and we're going to move our flap, our gingival joint, apically. So we're going to fix that flap with 2 screws. One screw you can see here, the other one is covered by soft tissue, and this is the situation 3 weeks later. Okay, let's see how it was. This is the situation before. I mean, we have a vertical defect, but from the occlusal view, we have all the tissue here absolutely in the palatal, and after we have it there. So you can see now we have the funobestible in place, we have tissue, 2 implants in the centrals, and bone underneath. Okay, this is how it was before. And this picture, he sent us the patient with his phone from his home country, because it's difficult to have the following up live 5,000 kilometers away. And this is how it looks like a couple of years later. You can see we have pseudo papillas, little, but we are quite happy because the patient has teeth, they are fixed, he has bone, he has soft tissue, and is working quite well. And the last case, I'm going to talk, I know Pepo talked the other day about his mother also, posterior mandible, but it's the only part I didn't talk about. I talk about anterior maxilla mandible, posterior maxilla now, anterior mandible. So this defect, first thing we take a look is the bone peak we have on the mesial. So always check we have that bone peak. Look at that, we have 3-4 millimeters bone. If we measure here, if we leave 2 millimeters safe distance to the nerve, and with this little incision, we are going to reconstruct all the posterior mandible. Thin bone blade in the crestal, fill the gap with particular bone, and thin bone blade in the bone. This was the situation before, and this is the situation right after. As you can see here, we can see all the reconstruction. We place the implants. As always, we submerge it a little bit and take a look to the CBCT, the situation we had before. We have a cortical plate here in the crestal, and after the graft, it moved vertical upper. Now we have 2 new corticals, lingual and buccal, and this is before and after. Again, we can compare where are the nerves, the down part, and all the reconstruction. Oh, sorry. And of course, these big defects always, they don't have enough soft tissue. So we should place a fringe graft in order to have keratinized tissue all around our implants. We did at the same time, we did a second surgery. And this is the situation in 2013. We have our 2 implants, we have the keratinized tissue and the bone. And this is 4 years later, the implants, and I cannot distinguish the bone in between the implant, which is the grafted bone, with the regular bone of the rest of the mouth. All this work is here in this paper, and check it out if you want. And if you have any doubt, feel free to email us, to contact us through the social media, Instagram, or our email. You have it here. This QR code is for our website. If you want to check some clinical case, some courses, whatever you need, we are here, happy to help.
Thank you so much, Juan. I have to say, my friend,
Hello, Omid.
Hey, I have to say, your cases were massive. You know, that's the only way that I can describe your cases. Massive cases. You know, I think we cannot see any more complexity than that. And for me, the very, very interesting part was the one anterior maxilla and the anterior mandible that you presented, because I have to say, especially the case in the anterior mandible, you know, when the buccal vestibule and the floor of the mouth were almost in the same level, no tissue, no attached gingiva, no keratinized tissue, and that massive bone defects, your approach and yours, everything was just amazing. And really congratulate you on your approach, your skills. And it was full of data, for at least for me personally. I'm pretty sure everybody enjoyed it. And you know, it's very interesting. Because I know you're expert in this field and you've done lots of these cases with Jose, that he said you are his partner in crime. So that's true. So I want to know, I want to know your thought about this technique, because you're expert in it. One of the things that usually dentists may be worried about it is the exposure of those plates. And actually in the anterior mandible, you showed that the remodeling caused the bone to be shaped in a way that the original contour of the ridge is. And you showed it beautifully, that how that plate was in shape after 4 months, for example. So if it's the case that the bone will go through the remodeling to achieve the original contour of the ridge, so why we should be worried about exposure? why in some cases bone goes under remodeling, but why in some cases, uh, except going through the remodeling, it becomes exposed through the tissue.
I think that the exposure happen because of two reasons. One is bone distance. I mean, we do a free tension, supposedly free tension closure, and when the patient gets swelling, inflamed, it is growing because of the inflammation, and then it cannot handle that tension, opens. One of the reasons, and the second is when we have a flap really thin over our graft. When we have a really thin layer, soft tissue layer or on our graft, the exposure is easy because the blood supply of the flap, doesn't get to vascularize all of it, and we have exposure through the tissue. Even though there is no incision there, we can have an exposure there. So that is why we always avoid crystal incisions for vertical augmentation, not for horizontal. For horizontal, we go open approach, but for vertical, we try to do tunnel or approaches. And the another reason is we always wait months, 3-4 months after we remove an implant or we remove a tooth or these kind of cases in order to have not only soft tissue, but also thick soft tissue to cover the graft.
Yeah, good point. Good point. And also, you showed it in both anterior mandible and anterior maxilla. But my question is regarding the anterior maxilla because you did it through the tunnel and you placed 2 plates in the buccal. Mm-hmm. But your incisions are in the mesial and distal. My question was the way that you stabilized the plates in the middle part. How did you approach to screw the middle part? Because mesial and distal is okay because there is an incision, but what about the middle?
Really, really good question. Really good question. The thing is that when you have a tunnel, the problem of the tunnel is that you cannot see the whole picture at the same time. I mean, we are used to see all the graft at the same time. When you are working through a tunnel, you need to get used to see only a little part of every side of the graft. So what we do is we have an incision, we fix, as you really well said, in the mesial part, which is the closest part to the incision, and once we have fixed that, we move that flap in order to see other parts of the graft. Do you understand?
Yeah.
I don't know if I explained.
No. Okay. I understood, but I want to know now that you lift the flap to see the next area that you want to do the fixation. Do you do the fixation with the motor-driven handpieces or you go with the hand drivers to do the fixation?
We always, for that part that is far away from the incision, we work with the straight hand, and we always use long screws, 10, 12 screws. So we go with handpiece straight, and then with long screw, trying to achieve stability as farthest as you can.
Okay, so you don't screw in a vertical direction, you go in the oblique direction.
Yes, we go to the oblique. Usually oblique and going up, looking forward that bone which is there farther the defect.
Yeah, great. That was a great. Yeah, and regarding the fixation of the plates in your technique, whether it's vertical or horizontal, do you use self-thread screws? I mean, do you first make a perforation in your plates and then you do the screws, or you use the screws straightly from the plate of the bone and go inside?
That is another really good question, very good question. And we always place the screws, we drill it in place. Why? Because if you drill the screws, yes, in place, in the final place, if you drill the screws outside, and imagine you drill in a 45 angle,
Mhm.
and then you place it and you screw it. The thin bone blade is going to move until it gets to that 45 degree. So they're going to move, they're going to try to get that inclination. So what we place it in the final place, we hold it hard with a mosquito, and we drill in place. We
Yeah,
don't drill outside. We don't drill outside. We drill always in place.
yeah, great. And you know, your topic, I have to say, Juan, is very interesting. I think we can talk about it for a day, but because I know your time is precious, so I want to make it short. But you know, my one of my last questions is this: um, when you want to do this technique for
Mhm.
vertical grafting, especially, I want to mention the cases that you presented in the lower mandible. Um, the level that you're putting your plate
Mhm.
is regarding the level of the platform of the implant that you're going to place in the future, right? Because I think if practitioners place the plate very superficial, then the risk of exposure are going to be higher. Because if you look at your case in the lower mandible when you extracted two lateral incisors, the level of the papilla for the remaining teeth, for example, was here, but that was the level of the papilla. So
Mhm.
actually the level of the margin of the future crown gonna be here. And the level of the platform of the implant should be about 3 millimeters below that. So is it the criteria for you to decide
Mhm.
where to place your plate in the augmentation or no?
Not exactly, because the thin bone blades has to be touching the bone peaks. So the level of the crystal thin bone blade is determined by the bone peaks in the sides.
Uh-huh.
So if we have a bone peak here, the thin bone is going to be like this.
Mm-hmm.
You understand?
Yeah.
We never let the thin bone blade not touching, because if you leave it on the air and the bone peaks here far away, we're gonna get soft tissue growing around. So we always try to touch with the bone peaks the thin bone blades. That
So
is what determine the level of the blade.
yeah, but you said that, for example, when the bone peaks are uneven, for example, one is here, but one is here. So what will happen? Do you place the plate like this,
Mhm.
or you try to match it to be in a horizontal direction?
No, we place it like this.
Hmm.
We try to get that vascularization from the bone peaks.
So what will,
Yes.
so you know, my question is this: if you place your plate oblique way like this, then what will happen to your implants? You place one of them here, one of them here, so that won't be any problem in the future.
No, no, what I would do is I would place both of them on the same level, and then I would graft with soft tissue to equalize,
Yeah,
to make it the same.
yeah, yeah. Great point.
Because we cannot reconstruct over the frame. We cannot reconstruct over the frame. That is our limit.
Great point. Great point. Juan, I have to say, I truly, truly enjoyed your presentation. And, you know, it was full of data and full of critical points that me personally say that you doesn't you don't see it often in presentations usually, so it's a one of the kind. And really thank you, really, for sharing it with me and all the audience of the hot seat. And it means a lot, and hope to see you very, very soon, my friend. And God bless you. Hats off to you.
Thank you, Omid. It was my pleasure for your invitation. I'm glad you like it, and thank you so much again. It was really good. Thank you so much.
Thank you so much, my friend. Take care, and we'll be in touch. Thank
Bye
you.
bye. Take care.
Have a good
Ciao.
day. Thank you. Ciao.